Good morning, everyone. Thank you for being here today. We have some wonderful people who are speaking with me who bring a vast amount of experience and expertise on this important topic, and I'm honored to be sharing this platform with them today. My name is Eileen Wilson. I've been a safety professional for over 25 years, working within the healthcare industry since around 2014. I'm a healthcare practice leader at Safety National and currently on the board of directors for the Association of Safe Patient Handling Professionals, or ASPHP. For those of you who might not be aware, Safety National ensures the workers' compensation of around 3.5 million healthcare workers throughout the United States. And we have with us today Susan Gallagher. Susan holds a PhD in policy ethics from the University of Southern California. Dr. Gallagher is certified in bariatric nursing and is a certified safe patient handling professional. She is formerly a bariatric senior risk analyst for Stevens & Lee and consultant. Dr. Gallagher has served as associate editor for Workplace Health and Safety since 2018. She was the 2023-24 president of the Association of Safe Patient Handling Professionals and served as program director for the ASPHP National Safe Patient Handling Mobility educational event since 2020. Dr. Gallagher is the author of more than 200 peer-reviewed articles, books, and book chapters. She is currently executive program director for the National Bariatric Solution Conference, which is an interactive, immersive, and interdisciplinary conference held each year in the fall. And next we have Tracy Carr. Tracy is an international consultant and patient advocate for people of size. She has over 20 years of experience offering independent advice to leading healthcare companies across the globe. Ms. Carr works with staff, clients, and students offering advice and support to assist in the care provided for larger people. In addition, she works with teams delivering training in the moving and handling of plus-size patients. And last but not least, we have Rhonda Turner, who has 38 years experience in healthcare, traveling from certified nursing assistant to doctor of nursing. Her current role is Northern Colorado Stroke Program Manager, and she also leads the System Safe Patient Handling and Mobility team, focusing on fall prevention, staff injury prevention, caring for patients of size, mobility, and engaging every level of healthcare across the continuum of care. She is a national and international speaker, published author, currently serving on the ASPHP Board of Directors as Executive Secretary Treasurer. Her mantra is empowering others to lead the future. And with that, moving on, to give a quick overview of what we aim to cover, the next several slides throughout this presentation will bring light to the questions posed on this slide. From there, we'll segue into the relationship between worker-patient safety and hear from someone who has lived the patient experience. And to wrap it all up, we'll learn how we can make a difference in protecting both healthcare workers while protecting people of size in conjunction with preserving dignity. Let's get started. So there's several aspects to the reason for this webinar, with the first being an understanding bariatric challenges. Individuals of size pose unique health challenges, including mobility issues, increased comorbidities, and specific requirements for safe patient handling and transportation. This webinar will focus on educating healthcare professionals, caregivers, employers about the complex of caring for bariatric patients, which helps in understanding specific safety concerns that arise. And next, enhancing patient and staff safety. Proper training on bariatric safety can reduce the risk of injuries in both patients and staff during transfers, repositioning, and transporting patients of size. Being a workers' compensation carrier, we of course see a number of claims. I think most of us know that the #1 cause of injuries within the healthcare industry is strains and sprains with both frequency and severity. NIOSH states that the human body should not lift more than 35 pounds. Certainly when we talk about this in the way of moving and transferring people, unless it's a very small child, we really need to think about what that looks like and that we're taking proper precautions to do things correctly. Teaching appropriate lifting and transferring techniques, and using specialized equipment that can minimize the risk of musculoskeletal injuries among caregivers and ensure the patients of safety is of utmost importance. And then there's compliance with regulations and standards. There's legal and ethical responsibilities. Healthcare facilities and organizations must comply with regulations related to patient safety and care. Understanding best practices with bariatric care can contribute to overall quality improvement initiatives within healthcare settings. Improving communication and collaboration. This should begin with an interdisciplinary approach by bringing together healthcare professionals from varying fields, from nursing, PT, physical therapists, dietitians, etc., will help foster that collaboration and enhance communication regarding bariatric care, leading to improved practices and positive patient outcomes. And also promoting awareness and sensitivity. Increased awareness of bariatric safety can help reduce the stigma experienced with a person of size by promoting understanding and empathy among caregivers and peers. Educating staff about cultural and social factors influencing obesity can lead to more compassionate and effective care. And then empowering patients and caregivers. This can begin with education. Providing information on resources, support groups, and self-care strategies empowers bariatric patients and their families to take an active role in their health and safety. It's also important to encourage advocacy. Knowledge gained in this webinar can encourage participants to advocate for better resources and policies in support of bariatric care. And then moving on to the impact of obesity on employee health. As I touched on earlier, moving patients of size in healthcare settings poses several risks and challenges for both the patient and the healthcare provider. Here are some of the dangers associated in this practice. Injuries to the healthcare providers. The transferring, moving, repositioning of patients of size can lead to musculoskeletal injuries for healthcare workers, including strains and sprains and more severe injuries to the back, neck, shoulders, arms, especially if lifting techniques are not properly used or the proper equipment is not used. This can lead to severe injuries over time or even severe acute injuries if not done properly. And let's not forget about the patient risk of injury. Improper lifting techniques or inadequate support can result in injury to the patient. This can include skin tears, bruising, or more serious injuries such as fractures or dislocations, particularly if the patient is unable to brace themselves during the transfer. Equipment limitations. Many healthcare facilities do not have the appropriate lifting equipment designed for plus-size patients, such as specialized hoists or slings. Using standard equipment for said patients can lead to equipment failures or accidents. And with falls, transferring plus-size patients without adequate support significantly increases the risks of falls for both the patient and staff involved in the transfer or repositioning or movement. Falls can lead to serious injuries, including head trauma and or fractures. And then there's the psychological impact. The experience of being lifted or transferred can be distressing for plus-size patients, potentially leading to feelings of embarrassment, shame, or anxiety. This can impact their overall healthcare experience and willingness to seek care. Infection risks. In some cases, improper handling can also lead to skin breakdown or pressure ulcers, particularly in patients with limited mobility. This increases the risk of infections, which can complicate recovery and extend hospital stays. Inadequate training. Not all healthcare professionals receive specific training on how to safely lift or transfer plus-size patients. This lack of training can lead to unsafe practices and increased risk of injury. In emergency situations, the urgency of the situation can lead to hasty and unsafe practices. The lack of time may prevent staff from using proper equipment and safe techniques. There should be a comprehensive plan in place that involves regular staff training and ensuring proper protocols and equipment are available. To mitigate some of these risks, as mentioned, healthcare facilities should invest in appropriate lifting equipment, provide staff training on safe lifting techniques, and promote a culture of safety that considers the unique needs of plus-size patients. And then I'm going to talk a little bit about demographics here. So to elaborate on this slide, as we've already discussed, injuries among healthcare workers, as we know, are a significant concern and can vary based on several demographic factors as well. Here are some key points to consider. With gender, women are often more likely to experience musculoskeletal injuries related to patient handling. With age, it can be both with younger and older. Younger healthcare workers may experience higher rates of certain injuries, particularly those related to workplace lifting because they may not have been properly trained, or they may have underestimated a certain lift or transfer. This could be from, again, lack of proper training or just not having the proper education and policies within that hospital or healthcare setting. Conversely, older workers may face risks of chronic injuries, such as back pain due to cumulative exposure over time, shoulder strains, tears, sometimes debilitating. Within job roles, different roles within the healthcare industry have varying injury rates. For example, nursing staff, nursing assistants, and home health aides often report higher rates of musculoskeletal injuries due to lifting and moving patients. Work environment also plays a role. The setting can influence injury rates. High stress environments with higher patient acuity levels tend to have more incidences. A needs assessment should always be conducted for safe patient handling, and specifically where there is bariatric care. It's important to ensure the proper equipment is available and that staff is properly educated. With the experience level, new employees might be more susceptible to injuries due to inexperience with safety protocols and procedures, while seasoned workers may develop some resilience to certain risks, but certainly experience cumulative trauma disorders from long-term patient handling. Full-time versus part-time. Part-time workers may experience injuries different, often having less familiarity with workplace protocols. Full-time workers may be exposed to more incidences over time, causing chronic strains and chronic injuries. In geographic locations, injury rates can also vary by region, influenced by local healthcare policies, workforce regulations, and availability of safe equipment and training. So there's many degrees of demographics and the different roles that each healthcare facility should play in training and educating their staff. And there's so many things to take into consideration. And without further ado, I am now going to turn it over to Susan Gallagher.
Great. Thank you very much, Aline. Yeah, it's a pleasure to be here with the three of you and the team at Safety National and all of you viewers. So the first thing I want to talk about, and I know this is a very busy slide, but there's just a lot of information we wanted to share with you, is how we use either patient handling technology or patient handling processes and systems to address both worker and patient safety. So a couple things on this screen. First is the Association for Safe Patient Handling Professionals, of which Aline Wilson, Rhonda Turner, and I are all board members of that association. That association was put together really to promote safety for not only patients, but for healthcare workers as well. It's a wonderful organization, and if you're not familiar with it, I would encourage you to look at that. The other thing I want to talk about are the American Nursing Association standards, and these are interprofessional standards. So they address all of us who are involved with patient handling and mobility. Those were originally done in 2013, and then they were revised in 2021. And so a lot of great information. What you see on the left-hand side of your screen are the 8 principles or the 8 standards. And so I'm not going to read those to you, but those really start with establishing a culture of safety. And I think they end with that as well. I believe there's circularity to those 8 principles. In the center there, you see the implementation guide to the Safe Patient Handling and Mobility Interprofessional Standards, which I wrote in 2013. That book is kind of a recipe book on how to implement those 8 standards. But there's more to it, right? So the mobility screening that was originally the Banner Mobility Assessment Tool, now we refer to it as the Bedside Mobility Assessment Tool, but there are 4 steps to that in identifying what your patient's mobility level is at that time, and then what equipment can be attached to that. And that's what you're seeing here on the screen in the red, gold, yellow, and green. So in the next slide, so this all kind of summarizes what's available to you to help address not only worker, but patient safety as well, in terms of how we decide what patient handling technology ought to be put in place based on policies and procedures. Now, I want to share a little demographics as well, and we are talking about bariatrics today, or our plus size patient population. We do know that 42% of patients in US hospitals today have a BMI 30 or greater. that BMI categorically identifies that individual as having the condition of obesity. So we know that this is the patient population that falls into the category we're discussing today. We also know that the rate of patients in all settings, whether it's acute care, home care, irregardless, weighing greater than 500 pounds is rising disproportionately. So, we feel like we've done a great job with managing the needs of those individuals whose weights range from 300 to 500 pounds, but we are seeing more and more patients in those upper limits. Now, the next two bullets talk about a study that was done by Dan Drake and others, where we talked about patients who were manually handled, who had a BMI greater than 35, were associated with almost 30% of worker injuries, almost 30% of lost time, and about 37.2% of restricted time. So in this particular study, the team looked at the OSHA 300 logs to be able to identify this data, and they found that lifting, turning, repositioning our larger patient population without equipment, just with body mechanics, did result in worker injury. So I think that's one of the reasons why we're talking about this topic today, is how do we protect our patients and how do we protect ourselves? Next slide. The other thing, while we're getting ready for the next slide, and I think, Aline, you talked about this earlier, is that when we talk about that level of sensitivity, we have a higher level of sensitivity toward all of our patients if we have the equipment we need to perform those tasks. So let's look at this. So let's go again, looking at the BMAT 1, 2, 3, and 4, and you can see on the pictures here that there is equipment that's attached to each one of these. For example, in BMAT 1, we want to do in-bed repositioning. So there are tools that are available to you that can help you with repositioning the patient, whether it's turning the patient, whether it's doing in-bed range of motion. On BMAT 2, where the patient's a little bit more independent, there are tools that are available to that end. So a lot of technology is available based on what your patient's mobility level is. Now, Rhonda shared these two pictures of staff members talking about what is patient safety to them. And you can see in the upper right-hand side, the gentleman saying, patient safety to me is peer collaboration for fall prevention. The woman in the lower portion says, patient safety to me is purposeful rounding, avoiding falls, and now the BMAT, and to know the BMAT and to reduce back injuries. Really, it's all overall patient worker injury that we're wanting to reduce. So in the next slide, I talk a little bit about some research that's being done around the world that I think is important for us as we segue now into Rhonda Turner, Dr. Turner, talking about her project. But I want to talk about this first bullet, which I make reference to as the international study. Both in Scotland and Spain, in fact, that's where this study started, and then it opened up to nearly 12 different countries. But it was reported in a 2023 study that explored the detrimental effects of hospitalization on the health of older adults. And could that be countered by physical activity? Now, we do know in the States that the rates of obesity among our patient population age 65 and greater is about 50%. So when we talk about age-related care, we can't disregard how important weight-associated age-related care is going to be to us. But what they found in the initial study was that older hospitalized individuals, 95% of their time was spent either in a chair or a bed. And what they discovered is that if they could get patients up even 25 minutes a day, it would reduce that deconditioning that occurred as a result of hospitalization. And 50 minutes of movement was optimal. So I guess the question that the study posed was, how do we organize hospitals and healthcare organizations to prevent deconditioning associated with this lack of mobility when older patients are admitted to facilities? So in terms of what's happening with the mobility movement in the United States, yes, a lot of hospitals are looking at that. But I think unless we can address the needs of our patients who are upsize, and we can incorporate safe patient handling and mobility equipment, it's very difficult for nurses at the bedside to be able to engage in the mobility movement. And so now I would like to introduce Dr. Rhonda Turner, who's going to talk a little bit about Banner Health and some of the really cool ways that that organization has organized itself in such a way to prevent deconditioning. Dr. Turner?
Hi, Susan. Thank you so much. I appreciate that introduction. So pardon me while I'm having a few technical difficulties, and I'm a happy clicker today. So, all right, so we did have a system-wide focus. And the reason why we recognized that we had gaps within our Banner's Health system is in 2015, we did a complete gap assessment, and we realized that we really lacked hands-on training to really ingrain that most nurses need to know, have that muscle movement and that muscle learning. So we created a system-wide focus to bring back our hands-on classes. And we did create the BMAT. However, it doesn't matter what assessment you use, as long as you use an assessment and apply expectations with that. So with ours, we have the BMAT. So BMAT level 1 is strict bed rest, and we want to reposition them. We want to start promoting that mobility because any mobility is good mobility. BMAT level 2, we want to really get into that passive and active range of motion, and we want to start getting those patients out of bed at least 3 times a day. And whether we do a lateral transfer, but however we can get those patients out of bed and get them moving is key. And BMAT level 3 is when the magic starts happening and we really start to see that healing happen, where we are marching in place at the bedside. We're starting to walk up to 100 to 150 feet 3 times a day and really encouraging the staff to do that. And then BMAT level 4, they should be independent or close to back to baseline to going home. So that's really where we want to get them. So, and you can see we have different things happening in the slide. And then I just want to give a shout out to my husband, Ronnie Turner up there, who really started promoting to decrease staff injuries, especially to the front line. So we've been doing skills line. He's a champion. He challenged the doctors to get on the equipment so that when they go into the patient's room, they say, Ronnie's going to come in with the row walker and ambulate you 4 times a day. And that really started this partnership between the caregivers, the patient, and the physicians. And it was really, it really helped our open hearts to start to recover sooner. So we did that. And then Dr. Stephen Lucky, he said this in 2012, and it really engraved my heart. Mobility is a precursor to death. And it's so true. When we're not moving and we're not engaging our muscles, our brain, we start to slowly become disabled. So we created a system-wide early mobility practice, and in 2022, a new steering team took over and they created this Move Bingo. And I'm so excited to be able to share the most recent, it was published about a month ago, and you guys have that handout. So if this is something that you're interested in, you can create it, your own assessment or your own bingo game to match your assessment. So the goal is to get people up and moving and get them engaged in care. And we have there's in every line except 2, you can promote ambulation. So our goal really focused on BMAT level 4. And those are those independent people that may just don't realize that they're hanging out in bed all day. So really encouraging them to get up and moving. And we have seen incredible outcomes. And the patients love it too. I want to talk about Errol here. So Errol is one of our first patients with COVID, and I had the incredible opportunity of watching him throughout his hospital stay and then meeting with him about a year after his hospitalization. But the things that he remembers is he knew that when he saw that white horse, or the non-mechanical stand aid, we call it the white horse, and he knew it was time to get up and move. And so he really had to consciously talk himself into it. And he was vented, he coded a couple times, and he was in ICU for 65 days. It was just, he had such an incredible journey, but he knows mobility was a key. And then he didn't even know when I was interviewing him what the goal is, to connect the heart to the caregivers, right? So he said the RN said studies show that people that get out of bed 3 to 4 days will go home sooner 3 to 4 days. The doctors are good and great, but it's the nurses and the CNAs that are the heartbeat of recovery. And I did create a video. arrow from COVID-19 to Cancun, and he ended up just thriving. And he knows it was because of mobility and getting up and moving. So I have this cool video of him dancing at the end of the video. It's awesome. So you guys can Google that and check it out. But truly, it takes all of us. It takes the physicians to get that, hold people accountable, especially the patients, and they love to be bragged on, the patients. So just one result, we have different metrics, and of course, anything that you want to implement, you want to make sure that you find a way to measure it to see, so you can watch your progress and watch your journey. So we took a decompensation rate on post-acute discharges as one outcome. And we saw, so that means that if a patient came in as a BMAT level 4, we want them going home as a BMAT level 4, that independent, and we don't want them a 3, 2, or 1. So, and we really want the physical therapy to focus on those 1, 2s, and 3s so we can get them to a 4. But we saw a decrease in decompensation rate. We also saw a decrease in the post-acute discharges to rehab, and that's phenomenal. And that's just encouraging patients to get up and moving. But it gets even better. If I can get to the next slide. In our first phase, which this was our outcomes from January 2022 to September 22, we saw 141% decrease or increase in ambulation BMAT levels 3 and 4. We saw daily ambulation documentation, an 81% decrease, and a lot of time it's just reminding staff to document. We saw the compliance, we saw range of motion increase, we saw daily sitting in the chair increase. And then on our first dashboard, we looked at invol and catheter days. We saw a decrease in catheter days. We saw a decrease in falls with injury, length of stay, pressure injury rate, physical therapy consult rate, all decreased. So when we presented to the system executives, because it's important to network at every single level, they really took a hold of it. And this is when we implemented the bingo. So in an 8-month period, we also saved 11,980 patient days. So y'all think about that. That is huge. That's getting our patients home quicker to our families. And as a result of that, we saved over $14 million just in an 8-month period. And that, again, that's just focusing on BMAT levels 4. So think about what's going to happen when we continue the process and go really drive that focus to 3, 2, and 1. And this is why we do it. Mobility is the single intervention that has the greatest impact. And again, that hospital-acquired disability that Susan was talking about, it slows down the healing, it slows down everything. And you can see that it really does touch, and we've seen it happen at Banner, you know, the decreased falls, the decreased delirium, length of stay, patient confidence goes up. It just impacts everything. And again, it's a multidisciplinary approach. But when it comes to really connecting to the heart of the caregivers, you got to be proactive. And it wasn't until we found the implementation guide that that really taught us how to bring those ANA standards to life. Because as I've shared, or Eileen shared, I've been in healthcare for 38 years, and I've seen the cycle, you know, where you could have every 6 months to, can y'all still hear me?
Well, we could hear you, Rhonda.
Yeah. Well, yeah. Okay, here I'm back. I think I'm back. I'm so sorry, you guys. But really trying to be proactive and find a way to engage the caregivers, and especially when it comes to caring for patients of size. So we use a bariatric suit from the Celebrations Institute, and we got it on the aircraft, we got it, and what we learned with every scenario, I go in thinking patient handling, happy prevention, fall prevention, but what comes out of it every single time is conversations around empathy and empathetic caring. So I just think it's a beautiful thing. But when we had it on the medevac, in this middle slide up here, you can see they were talking about how we lose that eye line, or that line of sight that the caregivers need. And then there's a slide where she's trying to push the patient's hip into the aircraft, and she said, I try to be empathetic when I give care, but this is what we have to do. So we had a lot of lessons learned just over the using the medevac example. And then we also manual car retrieval, especially when it comes to patients of size. When we manual lift, it just puts the caregivers at risk, it puts the patient at risk. So we utilize a suit, and then we saw in the safe training environment that the patient's respiratory status was impacted. So we could pause, we could regain our ideas and revamp our process to get that patient out. So again, this proactive learning with simulation suits and scenarios is huge. In the next slide, I have some more. Once we get them into the ED, I've had patients come up to the floor and they've had skin injuries just from being on the gurney because they were wedged in the gurney. So getting the right size of gurneys for all of our patients. I had the opportunity one time to interview Tracy and ask her what great looks like. And really is that, to sum it up, it's a beautiful conversation, but her response, but to sum it up is us being prepared for all patients and not making them feel like they're special. So really using a bariatric simulation suit or plus size suit really helped the staff to it was eye-opening, for so many. So again, we did a floor rescue in PACU, and the staff said this is about as real as it could get. And people, when you do simulation and scenarios, make sure that you do a solid debriefing. We had people, and it moves people to tears. Like, what if that was my mom, or what if that was my patient on the floor? And this actress that was a model, she was so good about expressing anxiety, and she saw the staff work. They didn't know what to do. And the difference in the staff leaning over versus sitting down was all the difference in the world. And then, a lot of the conversations at the end of the training sessions, they'll say, it'll be that awkward silence, and somebody will say, I feel so overwhelmed when I go in to take care of a patient of size. And it just opens this whole awesome conversation that will bring goosebumps every time, because people start really thinking about it. And that's when you're connecting to the heart, when you're having those solid conversations. And I had one staff member who was a model said, I just will change how I approach every situation. And that's a beautiful thing. So really how we act, our body language, what we say truly impacts the whole aspect. So Susan, you want to talk about a safe way to catch a patient, is there?
There is no safe way to catch a patient. Yeah, I think the fear of patients falling interferes with mobility. And I think, when we talk with clinicians one-on-one, we say, what's the hesitation? A lot of times there's staffing, but a lot of times, and in the international study, talked about how we feel safer when the patient's confined to bed because we don't have to fear that they'll fall. And so I think this gives us an opportunity to really talk through, what equipment is available to prevent falls in the first place. And I think we've talked about that. Even when you assign the BMAT, you identify the mobility level of your patients and then assign proper equipment to that. But Linda Cohen and others did this paper where they used simulation to measure the risk to the caregiver with catching different patients in terms of falling. And they found that there was no safe way to catch a patient. So I think that's important for us to know and to understand that that's one of the reasons why we really want to have proper technology in place when we are mobilizing patients to prevent falls. So with that, I'd like to introduce Tracy Carr, who I've known for a very long time. I think it's been over 10 years now. We co-present a lot. She has so much to say about many aspects of healthcare. And so I'm going to let Tracy go ahead and share just a little bit about herself and some thoughts she might have about mobility. When we take questions, I want you to, put your questions in, and we can ask Tracy to respond to those as well. But Tracy, welcome. It's wonderful being here with you today.
Thank you so much, Susan, for the introduction and for giving me the opportunity to address your audience. So as you can probably hear, I'm English. I hope you'll forgive me for that, everybody. My life is completely ordinary. I work full time. I live in an unmodified house. I drive an unmodified car. The only time my life ever really gets complicated is when I try and access healthcare. And it's literally a matter of life and death. Health is the one thing that affects everybody and matters. So Currently, I'm about 440 pounds. At my heaviest, I was 540 and possibly more. I was thin as a child. I grew up fit and active, and then I hit a period of my life with severe depression. My coping strategy was overeating, compulsive overeating. And, you know, here I am, aged 57. I'm still carrying the weight that I put on when I was 30. I'm down to 440 pounds, but I live my life as a person of size. Yeah, it's healthcare is the one thing that gets complicated. And seeing all the lovely work that Susan and Rhonda have done, I'm in awe of it all, because we need the science behind it all. But just to tell you, as a patient, you know, my health is pretty good. I'm not diabetic, I'm not pre-diabetic, my blood pressure is fine. I have been hospitalized for appendicitis, for a pulmonary embolism, and for a hernia repair. But when I'm in the cared for situation, the one thing that terrifies me is that somebody will hurt themselves by trying to help me. You know, I'm aware that somebody not paying attention could end up with a career-ending injury. So in my mind, if I break a piece of your equipment, I will be embarrassed but possibly cross that I've been put in that position. If I hurt myself, then I will be more upset. But the one thing that would completely devastate me would be if somebody hurt themselves by trying to help me. And you know, we can be quite a difficult patient group. So if you ask me to do something when I have no confidence, I'm not going to actually say to you, I don't trust your technique, I don't trust your equipment. I'm just going to say no, and I won't explain. You'll probably mark me down as being, you know, uncooperative or whatever, but it'll be fear that is stopping me, fear on my own behalf and also fear on your behalf. It's, you know, as a patient of size, my physical shortcomings are obvious to everybody when they see me. So from the very first moment a healthcare professional sees me, I can sense that they're treating me differently. And, you know, there's fear on both sides. And unless we can communicate and resolve that, it escalates and we end up with no relationship. So to build a therapeutic relationship, we need to communicate. And that means, you know, you lovely people listening to seminars like this, and Susan and Rhonda doing all this amazing research. So Susan, does that sort of help set the scene a little?
That does. Thank you so much for sharing, you know, about yourself. Let's think about when you have been hospitalized. Do you feel that healthcare professionals are reluctant to get you up and out of bed, or embrace to help you get up and out of bed? Just tell us a little bit about that experience, if you can share that.
Well, I've been talking to audiences like this for over 20 years now, and when I started, the ethos of professionals was very much about safe storage, putting a bigger person into a bed and then managing everything in the bed. There was no concept that rehabilitation was, you know, a realistic goal. And thank heavens that is changing. But I had one, I was about to have a general anaesthetic for my hernia repair, and I was wheeled into the surgery, and I was vaguely aware there was a very complicated discussion going on, which started to make me anxious. And then I asked somebody and I said, what's the problem? And they said, we don't know how to move you from the trolley onto the operating table. And I said, well, I can do that. And there was a bit of a hush, and obviously nobody had considered that I was able to self-mobilize. So with some assistance, obviously, I got off the trolley, I got onto the table, and I had my operation. But it occurred to me afterwards, you know, it would have wasted the operating theatre time, it would have wasted all the staff's time, my operation would have been delayed, which would have had a bad effect on me. And it was all because the communication about what my current level of activity was and what I was able to manage. So we need to have more conversations, and we need to have them earlier in the process as well. I have found I think staff are risk averse, and you know, everyone talks about doing a risk assessment, but I always feel that the risk assessment will look at the possible risks of me falling if I mobilize, but they're not focused on the risks that are very prevalent if I stay in bed. You know, there has to be a balance between the two, and there has to be more knowledge and expertise in the hands of the caregivers to help them understand that it may be scary for them if I'm about to get up, but the risks of not getting me up are possibly even greater. I find it interesting, and I feel very much for the staff that don't have those, you know, the expert opinions and training to back up what we're sort of trying to explain about mobility.
So the focus of this webinar really is on worker and patient safety. So let's talk a little bit about worker safety in terms of helping you transfer, or, you know, those in your community who may have shared with you when a healthcare worker tries to manually move a patient of size. Talk with us a little bit about some of the barriers or things that might have been said, or any experience you might have in terms of, let's just say, even from transferring a person from the chair to a commode, either with equipment or without equipment. Do you have any experience with that, Tracy, you can share with the attendees?
I've been lifted on all kinds of equipment, but never in a situation concerning my own healthcare. It's only ever been sort of as a training exercise or a demonstration, which I'm very happy about. I have to say, if I was a patient and somebody said, we're going to hoist you now, I would be very resistant. As a, you know, I'm always interested to try new equipment and new techniques, and it's interesting to experience those. But even being fit and well, being mobile and active, having good muscle tone, probably wearing more than just pajamas, being hoisted is still quite a daunting prospect if you don't know and have complete confidence in the team that are doing it. I can remember one occasion I was leaving an aeroplane and the jetway wouldn't connect, and I asked for special assistance, and they said to me, would you be able to walk down the steps of the aeroplane? And I said, yes, of course. Yes, I can manage that, but I'll be slow, so I'll go last if that's okay. So everybody else got off the plane, and as I was walking down the steps, there was a lovely air steward who said, I'll walk in front of you, and if anything happens, I'll catch you. And from feeling completely confident about walking down these stairs, suddenly my anxiety went through the roof, because all I could think of is, now if something goes wrong, I'm going to hurt myself and I'm probably going to kill this nice gentleman. We were both going to go down this steel staircase, and all my confidence went. And once my confidence had gone, I know that my progress was so much slower. The anxiety, you know, you just come out in a cold sweat thinking what could happen here. And it's the same in a hospital setting. I was doing a seminar recently, and there was a healthcare professional, and they were talking about moving a patient who was probably in the 700-pound range, and they didn't have a proper solution, and 4 caregivers were either dealing with new injuries or dealing with exacerbated old injuries. And the thing I found really so touching was all 4 of them had really been at pains to hide the damage from the patient. They were so committed to providing good care that they didn't sort of speak up at the time. And I thought, this is just such a sad situation. You know, the patient isn't getting helped, and these 4 caring, highly skilled professionals are putting themselves at long-term risk. So, you know, as a patient group, me and my community, we have to be more open about expressing concerns and what our abilities are, what we can manage at home, what we possibly struggle with, and the best way to help us. As a patient group, we're not good at communicating that, and it would be fantastic if the healthcare community could maybe give a little more time to listening to us. I completely respect the expertise of everybody that I've ever come across in my care journey, but at the same time, I'm the expert in me. I live in this body 24/7. So ask me what I can do, what's easy, what's difficult, what would help, what wouldn't help, and let's work together to make a better solution for everybody.
Yeah, thank you. There is a question that I want to ask you that came in, and it is, what would you say about administration or leadership spending money for the right equipment or not spending money for the right equipment? How should we approach leadership around expending resources to address the situation we're talking about today, Tracy?
I think it really comes down to safety. If you can't move me safely, you should not be moving me. You shouldn't be considering doing something that might put me at risk or might put you at risk. Having the right equipment is not a nice add-on. It's not the cherry on top of the cake. It is the whole thing. You as a person of average size, you would expect to have a bed that will protect you from pressure damage. As a heavier person, there is no reason why I shouldn't expect the same. I should expect to be able to lie on a surface that will protect me from pressure damage. So any administrator that thinks that this is an area where they can save money, I think is they're misguided in terms of the length of patient stay, the quality of stay, patient satisfaction, bounce back rates. All of these things come into effect, and you as professional caregivers, you need to be able to advocate for the right equipment. Technology has advanced so far, there's so many technological solutions. We should not be manually handling people if a mechanical electronic solution is available. And as a small aside, as a person, if I'm told that a group of 6 people are about to lift me and reposition me, immediately I'm anxious, thinking about the damage that may happen. If I'm about to be lifted by a hoist and someone discreetly says, "This is fine for you, we have checked," then immediately I will relax, because I know the worst thing that can happen is that the equipment might fail, not that I'm going to damage somebody and possibly end their career. So yeah, get the equipment, advocate for it. This is not a nice to have. Same with, moving and handling equipment. This is not an optional add-on that your administrators should be on the fence about. You require it, and we as a patient group require it.
This is great. Tracy, every time we talk, I learn something new. And we've talked many, many, many hours, so this is really great. One more question, and Aline, I know that you have some questions that have come in. But, Tracy, you talked about confidence and healthcare workers having confidence. And a lot of individuals on this call today are at the bedside providing care every day, or they're individuals who are supporting through leadership roles those who are at the bedside. What recommendation do you have for frontline workers to gain confidence so that they can come in and say, Tracy, we got this. Let me just show you what we're going to do today. How do we gain that confidence? What are some ideas you might have, Tracy?
My heart goes out to anyone in that position who hasn't had the training, but I think the first thing you need to develop is a game face. So it's fine to say to your patient, I just need to check one thing, and then to go to a private space and have a mild meltdown and find the documentation that's going to help you, negotiate the situation. But if I can see on your face that you are losing confidence in what is going to happen, then I will lose confidence, not just in you personally. More than that, I will lose confidence in your organisation, in the location, in every aspect of all the care that I'm getting. Once you lose faith, it runs rampant across everything that I encounter. So I think develop a good game face, and then develop a toolkit. So if you encounter a problem with a patient of size in the first instance, it should be documented, it should be shared, it should be communicated to everybody else that's participated, and you should be able to solve the problem once, document it, and then have it in a library so that the next time you encounter that problem or that situation, you don't have to invent the wheel right from the beginning. You know, there's so much expertise that I'm sure all our attendees have. If we could gather everything that everybody knows together and keep it as a resource, then that would be fantastic, and it would help everybody. So if you have hints and tips and tricks, people, please share them, please teach us. You know, we want to know as well, and let's gather all this amazing information and keep it safe and all learn from it.
Great, thank you so much. Yeah, thank you very much, Tracy. Aline Wilson, do you have some questions for the group?
Well, I haven't seen any questions coming yet, but I just wanted to comment another thank you to Tracy, because this is just so eye-opening to hear all those, everything that you brought up from your side of things, because, you know, I think we do start to kind of get involved in looking at, as far as the needs assessment is okay type of equipment. And I know with people being caregivers, you have to have that human emotion. I'm believing that that's why most people go into the industry, is they do have that human emotion and that they want to genuinely help people. But then we don't, as a group, always, you know, people like me who aren't directly within healthcare or haven't been a direct patient, seen loved ones as the patient side and learned a lot from there. But just hearing everything you had to say and everything that should be considered, I think is really eye-opening for people.
Thank you, Ellen. And you know, I have to say, I'm somebody's daughter, somebody's sister, somebody's other half. You know, I've all of these roles, and everyone around me is thin, so they don't necessarily understand the issues that I go through. But you know, I'm just another person, and all the bigger people that you look after in your professional lives, they're somebody else's loved one. You know, we're all part of our human family, and we may be more difficult to deal with, but that doesn't mean that you can dodge it. I'm afraid we're just part of the variation of human beings.
Well, thank you.
I just
go
ahead,
Rhonda.
No, I just want to say a little something. So, Tracy, you were talking about this OR room. So I've had surgery twice in the last couple of years. My husband said both times I came out of anesthesia, I was teaching about air-assisted devices for a no-lift facility. How did you get me over here? Because I was also about 100 pounds heavier. And so that was my biggest concern. So it's ingrained in me. I know that because if I'm talking out of anesthesia, but I appreciate your open, honest, you know, your transparent perspective. Again, I always learn something as well. That's all I had to say.
Oh, thank you for the opportunity to, you know, talk to such an early audience. I really appreciate that you give me this opportunity. Thank you.
Thank you. Again, I do see some questions that have come in. Let's see. This one says, I'm a pre-licensure BSN program. I will be teaching mobility in just a few weeks. What is the most important thing? This test box is kind of weird. What is the most important thing you think I should be emphasizing with them? I should emphasize with them.
Talk to your patients. Make sure that I understand what is going to happen, in which order, who is in charge, who's going to say go. If you use technology, then there's a chance that I will be one of maybe 3 voices in the room, maybe me and 2 caregivers. If you're doing it manually, I may be only 1 voice amongst 6 or 7 caregivers. So make sure that my voice is heard, and that I understand that I have a right to consent or not consent if I don't understand or I don't have confidence. But yeah, just talk to me. Make sure that you're in my eye line, that I can see your face when we're talking. Give me some confidence and make sure I understand. And then every time you do it after that, it'll be easier and easier. But the first time I've as part of an experiment, I've been hoisted and moved, attached to something measuring my pulse and my blood pressure. And even with complete confidence in the people moving me, it has a serious physiological effect, you know, the anxiety of the situation. So yeah, a little care, let's communicate. That's the key to everything, I think. I hope that helps.
Thank you. Got another one here. Many hospital nurses and CNAs rely on the mobility assessment that therapy conducted. Who would you say are, okay, hold on, this question box is kind of weird. Again, what are the most common, okay, this is a really long question, sorry. Okay, many hospital nurses and CNAs rely on the mobility assessment that therapy conducted. Who would you say are the most important staff within the hospital setting to get on board with adding a VMAT or other mobility assessment tools?
Susan, I would think that's one for you or Rhonda.
Yeah, Rhonda, what was your journey?
Well, I think establishing that network, because I will tell you, when we first did that gap assessment, we saw how many holes we had, not just within one level of discipline. It was from bedside to leadership. And I think that's the biggest key. If you don't have an all-in approach or a one-team approach, no matter what assessment you're using, we've got to be able to support one another. And I think Dr. Nimit Agarwal, who's my partner, we published a few times, and he's just fabulous with saying, you know, success comes when we all move forward together. And he really emphasizes, when we rolled out the early mobility clinical practice, that it is not just one person's responsibility, it's everyone's responsibility. It's EVS, it's dietary. Anybody that goes in the room, especially with that bingo game when it's up and present, oh, you're almost to a blackout, or you got 2 more things for the line, like we can all communicate that. And I think that's been probably the greatest success we've had as a system. Any other thoughts on that, you guys?
I think that collaboration is great. And, you know, the ANA standards are interprofessional national standards. So really just talking with one another and networking, communicating. Absolutely.
Thank you. We're just about at the top of the hour. So again, I appreciate you all participating with me to conduct this webinar. I think it was really helpful, and I'm really appreciative of the expertise that was brought in, and especially with your personal experience with everything, Tracy. So again, ladies, thank you so much.
Thank you, and thank you to your audience. Thank you so much.
Yes, absolutely.
It takes all of us.